Hey everyone, welcome to The Explainer. Look, if you're a radiation oncology resident in training, you already know that pediatric oncology is easily one of the most high-stakes, hyper-protocol-driven areas of our entire field. The sheer volume of trial data, the staging rules, those incredibly precise dosing numbers, it can feel absolutely overwhelming. But don't worry, because I'm here to help you crush that cognitive load today. We're taking a super structured, top-down approach to the absolute highest-yield pediatric board review concepts. We're going to distill those massive rule books into the exact, actionable clinical pearls you need to know, both for your exams and, more importantly, for the clinic.
All right, here is our game plan for today. First, leukemias and CNS tumors. Second, Wilms tumor treatment paradigms. Third, Wilms radiation doses. Fourth, rhabdomyosarcoma. Fifth, retinoblastoma and SBRT targets. And finally, number 6, the must-know genetics and chemo rules. Let's get right to it.
Okay, part 1, leukemias and CNS tumors. We're starting our journey right at the top with the central nervous system and hematologic malignancies, specifically looking at how modern trial data is completely dictating our approach.
91%. I literally want you to burn that number into your brain. This is the 2-year overall survival rate for pediatric patients with high-risk acute lymphoblastic leukemia who received total body irradiation, or TBI, prior to their stem cell transplant in the landmark Forum trial. It is a staggering success rate, and it fundamentally solidifies our standard of care. Let's look at exactly how they pulled this off.
So, if we contrast the two arms of the Forum trial, it's actually pretty wild. They randomized pediatric ALL patients to receive either 12 gray of TBI plus etoposide or myeloablative chemotherapy as their conditioning regimen. And the TBI arm didn't just win. The trial literally had to be stopped early because the outcomes were that much better. I mean, the 2-year relapse rate was only 12% with TBI compared to a whopping 33% with chemo alone. Plus, the treatment-related mortality was significantly lower, just 2% versus 9%. So the big takeaway here is that despite all those late toxicities we constantly worry about with TBI, the growth and cognitive impacts, TBI plus etoposide firmly remains the gold standard for these high-risk kids because it unequivocally saves lives.
Moving over to primary CNS tumors, let's define a highly specific, heavily tested entity, the bifocal germinoma. This is defined by synchronous tumors around the third ventricle. Classically, you'll see them in both the pineal and suprasellar regions. Now, the huge clinical pearl you absolutely must remember here is that this is considered local regional disease. It does not require full craniospinal irradiation. After platinum-based chemotherapy, these patients are hitting near 100% complete response rates with just whole ventricle radiation therapy at a dose of 24 to 40 gray. And let me tell you, sparing the spine in a growing child is a massive victory.
Now contrast that immediately with non-germinatomatous germ cell tumors, or NGGCTs. These have malignant components and are definitively diagnosed if you see an elevated alpha-fetoprotein or a really high beta-HCG. Think over 100 to 200 IU. Unlike our bifocal germinomas, the paradigm for NGGCTs is so much more aggressive. It dictates maximal safe resection, followed by chemo, and then it strictly mandates full craniospinal irradiation at 36 gray, plus a 54 gray tumor bed boost. You really have to know the difference in these markers because it completely changes your radiation fields.
Pivoting over to the exact dosing rules for CNS involvement in leukemia, particularly T-cell ALL. Okay, so if a patient is CNS 1 or 2, which means they either have negative cytology or they have positive cytology but with fewer than 5 white blood cells per microliter, they get 12 gray of cranial radiation. But if they're CNS 3, meaning 5 or more white blood cells, a cranial nerve deficit, or a visible lesion on their imaging, we step that dose right up to 18 gray. And notice that the target field covers the entire brain all the way down to the C2/C3 inferior border. That's intentional. It makes sure we're covering the thicker dura up top where systemic chemo just kind of struggles to penetrate.
All right, moving right along to Section 2, Wilms tumor treatment paradigms, COG versus SIOP. We're moving down the body to the single most heavily tested pediatric solid tumor out there. So there's this massive global split in how we actually treat Wilms. Over here in North America, we follow the Children's Oncology Group, or COG, which strongly advocates for upfront surgery. The rationale? You get immediate, unadulterated pathological staging. But across the Atlantic, the International Society of Pediatric Oncology, SIOP, champions neoadjuvant chemotherapy first. Their whole goal is to shrink the tumor preoperatively to prevent intraoperative tumor spillage. Now, both protocols use an adriamycin and vincristine backbone, but their staging and their sequence are basically mirror opposites of each other.
And since we're mostly living in the COG world here in North America, you have to know exactly what upstages a patient to stage 3, which is what triggers the need for flank radiation. Enter the BSL-URPP mnemonic. A patient is stage 3 if they have a biopsy prior to resection, surgical spillage, subtotal resection or positive margins, lymph node involvement, an unresectable tumor requiring pre-op chemo, rupture, peritoneal implants, or if the tumor is removed in piecemeal separate pieces. Seriously, commit BSL-URPP to memory. It will absolutely save you points on the boards and help you out in the clinic.
Section 3. Wilms radiation doses. Now that we know who to treat, let's talk about the exact dose-volume rules. In pediatric RadOnc, knowing these precise numbers is just non-negotiable.
Let's break down how this escalating dosing logic builds. Your baseline, standard flank dose for a stage 3, favorable histology Wilms is exactly 10.8 Gray. But if the pathology comes back showing diffuse anaplasia or a rhabdoid tumor, we escalate that dose significantly up to 19.8 Gray. And if the patient has pulmonary metastases that just don't completely respond to chemo, whole lung irradiation is delivered at 12 Gray. Do you see how we risk adapt here? Standard is 10.8. High-risk anaplasia pushes you to 19.8, and the lungs get 12.
And look, timing is just as testable as the dose itself. If day 0 is your COG upfront nephrectomy, the absolute ideal time to start Wilms radiation is by day 10. The absolute latest acceptable start is day 14. That is an incredibly narrow window for a kid who is just recovering from major surgery, right? Contrast that rapid start with rhabdomyosarcoma, where radiation typically doesn't even begin until week 13 of their treatment course, right after they've had some significant induction chemotherapy.
Which brings us to Section 4, rhabdomyosarcoma staging, NRT. This disease is a beast, requiring us to navigate complex matrices of staging and some rapidly shifting trial data.
Okay, you literally cannot treat rhabdos without getting this distinction down cold. Clinical stage and surgical group are two entirely different things. Stage is determined by the tumor's site, meaning is it in a favorable or unfavorable location, along with its size and its nodal status. Surgical group, on the other hand, is based strictly on the completeness of the surgical resection. Are the margins negative? Is there microscopic residual? Or is there gross residual disease? Your final risk category, whether that's low, intermediate, or high, is a combination of both the stage and the group, plus the tumor's underlying histology.
And speaking of groups, your prescribed dose is heavily tied to that grouping, but the rules here just had a massive shakeup. Historically, the maximum dose for gross disease in rhabdomyosarcoma was 50.4 Gray. But then the ARST 1431 protocol came along and brought a major practice shift. Now, for group 3 tumors, meaning incomplete resection with gross residual disease that are over 5 centimeters at diagnosis and do not have a complete response to chemo by week 9, we actually escalate that dose to 59.4 Gray. That is a major escalation, and you definitely need to be aware of it.
All right, Section 5, we're going to pivot briefly to the head and neck for retinoblastoma, and then take a quick look at the emerging role of SBRT.
So retinoblastoma is usually caught nice and early, right? But in cases of stage 4B disease where there's CNS dissemination, our radiation fields get pretty extensive. After induction chemotherapy and stem cell rescue, we use response-adapted external beam radiation. And the precise numbers you need to lock in here are 36 Gray to the spine, 45 Gray to the cranium, and 50.4 Gray to the pineal gland. It is a heavy treatment for sure, but it's totally necessary for CNS spread, especially in hereditary cases, which often feature trilateral disease involving that pineal gland.
Now, shifting gears to a more targeted approach. SBRT is traditionally thought of as an adult modality, but it's really making its way into pediatrics. Recent data, like a great 2021 study by Elledge and colleagues, shows some highly promising local control for unresected osseous metastases in sarcomas using SBRT. They were hitting 95% local control at 6 months, utilizing a regimen of 40 Gray delivered in just 5 fractions. As systemic therapies get better and these kids are living longer, managing these oligometastatic bony lesions with short, precise courses of SBRT is becoming an incredibly valuable tool in our toolkit.
We are finally entering our last section, number 6, genetics and chemo rules. These are the absolute do not do this rules and key syndromic associations. Basically, your golden board pearls.
You absolutely have to be able to connect the molecular dots here. An INI1 mutation links directly to both a highly aggressive rhabdoid tumor of the kidney and atypical teratoid/rhabdoid tumors, or ATRT, in the central nervous system.
Meanwhile, DICER1 mutations are tightly associated with embryonal rhabdomyosarcoma, specifically of the genitourinary tract, alongside thyroid cancers. Recognizing these genetic flags instantly tells you exactly what other tumors you need to be screening that child for.
Okay, rapid-fire systemic rules to finish up. When your pediatric patient is actively receiving radiation, you gotta know when to pump the brakes on chemotherapy. Then Christine, that's generally safe and given concurrently. However, you absolutely must hold actinomycin D and doxorubicin during radiation therapy. Both of these are incredibly powerful radiosensitizers, and giving them at the same time as RT will cause severe, unacceptable toxicities, especially to the GI tract and the liver. Whenever you're writing your orders, double and triple check that those two drugs are paused.
Wow, okay, we've covered a ton of ground today, right? From the 91% survival of TBI in the Forum trial, to the rapid 10-day start for Wilms, to knowing exactly when to hold actinomycin D. But I want to leave you with a provocative thought here. As we see ARST-1431 pushing doses way up to 59.4 Gray, and parallel trials testing novel mTOR inhibitors and new molecular targets, how much longer will the fields and borders we memorize today actually remain the standard? As a rising radiation oncologist, your job isn't just to memorize these rules, it's to prepare for the targeted therapies that will inevitably rewrite them. Keep studying, keep asking the hard questions, and I'll see you next time on The Explainer.